Okay. All right. Let's talk about pathology. Pathology is something that probably gives most of us, we feel like we have Crohn's disease, right? You're like, oh, I think I'm going to have to use the restroom now because you get stressed out about pathologies. Why? Because there's so much to learn. It's not really our wheelhouse, is it? We're more orthopedic, neurological, and all that. We're like, yeah, I can, the cardiopulmonary system I'm good with, but the pathology of all that other stuff, I went into physical therapy so I didn't have to deal with digestive issues and right genital urinary issues. But the truth is it all impacts our patient care, aka systems man, right? And so we do have to at least have a way to put this information in a concise format so that you can accomplish what I call word association. So when a pathology shows up on the exam, and let's use Crohn's, for example, and you see that Crohn's disease, you at least have a few things pop into your head, right? What structures are involved? What's the safety consideration? What meds or treatment? And how did they diagnose this? What labs or tests were given for that? Because some of your questions might deal with you understanding medical procedures. You're like, why do I need to know this? Because you are educating your patient on expectations of managing their condition, which could impact their energy level, their endurance, their balance, and all those, their strength, and all those things that we're addressing, okay? And pain. And you have to have a basic understanding of, is this a pain that I'm treating, or does this pain not line up with the pattern, right? What do we call that when we're trying to decide, is this patient's symptom what we think it is, or could it be something else fooling us? What is that process of discerning that? Anybody know? We call that differential diagnosis. Is that back pain really from the stenosis, or is it metastasized prostate cancer setting up camp? And you're like, oh my gosh, so that's serious. So why do you need to know basic pathology of systems that you will never treat? Because you need to know when those are rearing their ugly head into something that you are treating, and you have to go, that's not adding up, okay? So you have to be able to, as I said, assume, predict, stereotype. You should know what lumbar stenosis acts like. So when something pops up, you're like, that's not acting right. That's when you would need to alert the PT, okay, who would then decide if they're alerting the doctor, stopping the treatment. So you have to have a working knowledge of other pathologies to apply differential diagnosis. That doesn't mean you're diagnosing. We know that you don't do that portion of the care plan. You do one of 5 portions of the care plan, interventions. You are an interventionist. In my world, I would change the name of your degree to physical therapy interventionist. You would be a PTI. You'd also have a bachelor's degree, but that's my little dream, okay? And we get rid of this word assistant because it just doesn't make things easy for anybody. I would call you an interventionist. If we want to jump on that soapbox, I'd call you a PT1. I'm a PT with a bachelor's degree. So you're learning as much as I learned back then, other than evaluation. But anyway, you know a lot and you've learned a lot. But we have to understand beyond our scope to understand that something is happening beyond our scope. Or how do you know? All right? Does that make sense? Why? So there's the why to get over the I don't want to do this, okay? Because I'm a why person. I'm not motivated if you don't give me a reason. I don't do it just because I told you so. So that's why we have to know it, okay? So what you have is a worksheet. We're going to physically fill in some of this today. And some of this will be based on your feedback. We are going to do endocrine system a little bit. I'm going to show you how do you work through that. And you will walk out of here and you're not going to be afraid of the endocrine system. And I have very little knowledge in the endocrine system. And if I can pull this off, you can pull this off. I'm not a pathologist. I hated that class too, okay? Still got bad dreams about it, but we have to do it. So when you're studying, this relies on you to do the work. You need to dig into your pathology book, into your review books, and you have to pick a system and you have to plot it on this paper. If you have too much information to put in the box, you're putting too much information. You're only writing what you really don't know or what you really want to write down, but if you can't fit it in the box, it's too much. We're not relearning it. Word association means when I say osteoporosis, you think brittle bones, compression fractures. Possibly they were on prednisone. Like that's what should pop into your head. And skinny little white lady, because that's your risk factor. Okay? So when I say prostate cancer, we don't treat that. But what are you thinking? You have to think about metastases, no ultrasound, all the conditions that could be, chemo brain, chemo fatigue, if they've had chemo, radiation, damaged tissues, right? And so we have to at least have a snapshot in our mind of that. That's why I say when you meet someone and you read their diagnosis, it's okay to stereotype them. Then when you actually work with them, you're throwing out certain stereotypes, you're adding in, you're like, oh, they're actually more advanced than I thought. This is hitting them harder than I thought. Oh, and then you add diabetes in there. Okay. And you're already trying to predict, what am I watching for this patient? What do I already know could go wrong? Okay. It's not a blank, I'm sorry. Your patient is not a blank slate. Well, I get to know. No, you need to know what they're presenting with so you can already predict what our problems might be. And it's great when we're kindly surprised that they're doing better than we thought. Does that make sense? I'm not being mean. I need to know if you come to me and say, hey, here's my list. I'm like, okay, I know what we're working with. And then I'm going to figure out and challenge those perceptions, okay? Okay. All right, so what I like to start with pathology, and whatever reference you're going to be using, I know your score builders has lots of pathology all over. But one of the scariest systems for me is the endocrine system. And there's going to be some questions on the endocrine system. You're like, ooh, does anybody love the endocrine system? Like, yeah, I got this down. I could be an endocrinologist. Okay, no, okay, good. So we're all in the same boat. We're all beginners. So when you look at endocrine, there's only two things about endocrine, and I'm oversimplifying. It's either too hyper or too hypo, right? The endocrine system is the hormonal regulator of the body with glands. You got the pituitary, right? You got the thyroid, right? You've got adrenal glands. So you have all these glands that secrete hormones that regulate the body. The problems happen when they're hyperactive or hypoactive. And there's a diagnosis that goes with most of those things. And there's precautions that go with most of those things. We just need to put them in a box. Is it hyper or hypo? Does that sound simple enough? Okay. So let's look at your chart. Now, when I say if you can't fit it in the box, you're writing too much, we're going to cut the boxes in half now. And that's, I'm being serious. Okay. I'm not messing around. So we are not going to overdo this because you don't have time to study pages and pages of one system. We have to get all the systems. All right. So what I do with this grid is I take one box and I divide it in half. So do that. You're going to get one gland per double box here. So on this first set of boxes that you've divided, we're going to take the pituitary gland first. Now, don't write anything yet. I'm going to show you what I do, and then you decide what works for you, okay? This is your process, so don't just copy or it won't make any sense to you. So what I do with the pituitary is I put the pituitary on the left. I write pituitary. So it's just on that full original box. It says pituitary on the side. Okay. So on mine, I put, and then the next one will be thyroid. The next one will be adrenocortical. But for pituitary, so now one of these is going to be hyperpituitary and one will be hypo. How does your brain work? Would you put hyper on the top and hypo on the bottom? Or would you put hypo first because it's less than hyper? Whatever one you want to do that. So I put whoever wrote that one put, or I'm going to put hypo on the top. Nah, I lied. I'm putting hypo on the bottom. That's just how my brain's working. I'm going to put hypo pituitary. And I'm gonna put hyper on top, but that's how I think. So the pathology is hyper and hypo. Now, those aren't really the pathologies, but we'll get to those. What is the most common hypopituitary condition? Hypopituitary. In general, what does the pituitary control? If you had to summarize it in one word. Pituitary. Growth, right? So maybe you might know hyperpituitary better. What's the condition that's associated with hyperpituitary? Gigantism, acromegaly. Remember that term, acromegaly? That's where your basketball players get like 7'5" and hands out to here. They have acromegaly or gigantism. So hyper is acromegaly. So since we already know that this is, spelled that wrong. We already know this is hyper. You wouldn't even have to write the whole word pituitary in there. We already have it on the side. So you could just put acromegaly under hyper. Acromegaly is hyper. Hypo is Simmons disease. Simmons, Simmons. So in your books that you have available, and if you don't have one, share with your friend, look up acromegaly and see what page that's covered on in your book, that whatever book you have. If you have a pathology book, great. If not, you should have it in your score builders. If you find it in the score builder, shout out the page number for the class. Acromegaly, it should be in there somewhere. Or look up pituitary. Yeah, it'll be worth it to you. Yeah.
Pituitary is on 463, but I don't see acromegaly.
Okay.
The growth hormone, pituitary.
Okay. So you've got some on 463 to 465. And again, different authors are going to, in the pathology book that the program in Ohio uses, it uses the acromegaly term. Anybody find it anywhere else? Hyperpituitary anywhere else besides 463, 464? Does it show, does Simmons in there anywhere? All right. Well, at least we've got the 463 page.
467 is a bit more.
Okay.
Here's your patho book.
Perfect.
You guys, please tell me you didn't sell your books.
No.
Okay.
You guys use that one too?
Yeah.
It's a familiar face. Whew. It is. I just didn't want you guys to have to bring 42 books in today. So that's why I'm willing to fill this one in for you. Okay. All right. Let's look at this one for a minute as you're getting your, you're kind of getting your balance there. So with the hyperpituitary, if the pituitary is about growth, let's just stop there. What would you expect to see in someone who has hyperpituitary? Are they big or little? They're big, right? Do you suppose that could cause problems? What systems would be strained by the body being so doggone big? Cardiac. Oh my gosh, there's cardiac problems. Like, this is almost like a common sense word association. You freak out, you're taking the test, you're like, oh my God, it's an endocrine question. Okay, was it hyper or hypo? And then all you have to think about is, can I kind of remember what that gland, that hormone does? Is it too much or too little? They're not asking you to be pathologists. They want you to know the most important ones. Okay, so how does someone become hyperpituitary? Typically, for whatever reason, there's an increase in growth hormone. So you can just put up arrow GH. Like, the cause of hyperpituitary is too much growth hormone. A lot of times with pituitary, the answer is there's a tumor on the gland for some reason. It's either causing it to jack up or go down. So it could be a tumor. But what we know about what causes hyperpituitary, even if you write increased GH, we have too much growth hormone. What are the safety precautions of acromegaly or hyperpituitary? You mentioned them already. They're going to have cardiomyopathy. Their heart, like the Grinch, is 2 sizes too small, right? So just think, hyperpituitary is the Grinch, this big scary thing without a heart. So it's cardiomyopathy. And guess what? If you can't write that small, just draw a heart. Like, this is abbreviated study, like word association. He's got heart problems, hypertension. Okay? That's not too much to remember. Big giant, hyperpituitary, too much growth hormone, going to have some heart problems. That's why what happens to the basketball players, they keel over on the court and they die.
That also makes me think of bodybuilders, because they take growth hormone.
Yes.
When they're competing, and so they have heart issues.
Makes sense.
Yeah.
Makes sense. Right. Good. Now, what type of treatment? Let's go ahead and put tumor here for cause, because that's pretty much. The treatment would be actually tumorectomy or excision of the tumor, right? Remove tumor. So take out the tumor. That's brain surgery. That's a little scary. What types of labs and tests and things do they do for someone with hyperpituitary? Well, obviously measuring your growth hormone in the lab would tell you, hey, you got way too much growth hormone, right? And then they can scan and things like that. What are you going to do during treatment if this person happens to have this condition? What would be something important for you? We could either put it here or we could put it here. Vitals. How about we just put it here because the box is empty? What vitals? That's all you're writing down for hyperpituitary. It's increased growth hormone, heart problems. It's probably a tumor. Arnold Schwarzenegger was right. Wrong. It's not. It is a tumor. And we test vitals. That's it. So let's say you know nothing else. I bet you we could probably answer most of the hypopituitary. What do you think that person's going to look like? And when do they pick up on this? Who do you know has ever had, like someone personally you know that's had hypopituitary? It's the non-growing kid. And they give them growth hormone shots. They're just not growing, right? So this could be congenital. It could always be a tumor, but this could be congenital, the low growth hormone. So they're born with it. So this typically you're going to see with kids. What do you think the main expression of this would be on the body? Not enough growth hormone. They could be small. On the cardiac system wise in that, you're looking at weakness, which is very different than your NBA basketball player who clearly is strong. And they might also have hypotension and some diabetes. But that's because now their endocrine system's all jacked up. But basically, even if you just wrote weakness, just weakness. Why? We're looking at a contrast. You're naming a gland and you're going, it's either one or the other. It's in this family or it's in this family. What would be the treatment for low growth hormone? It's a little easier than high growth hormone. You give them growth hormone. You give them growth hormone. How would you have tested this? Hormone test. Hey, your growth hormone's low, which is also linked to estrogen and some other things. Okay, so that's pituitary. You don't write any more than that. Then when you've got those two figured out in your head, you stop studying that one. Okay? And then you rewrite this pathology grid and rewrite it, the ones you don't know. If you don't rewrite your notes for the next 8, 10, 12 weeks, you're taking away an entire track into your brain. Writing. Okay? We want to whittle this down from a room full of stuff to a few pages of things. Word association. But you have to study it. Get your flashcards. Go back to your memories, whatever you have to. So that's pituitary. Does that make sense? Okay, let's try thyroid. Okay? Exactly. Okay, now this is easy because you've heard this more in common language. Who has low thyroid typically? Women. They're packing on the extra weight and they say, it's just my thyroid. Maybe it is. Maybe it's the potluck. I don't know. So for the woman who has thyroid issues, is it hyper or hypo? Typically the weight gain one. Hypo. I have low thyroid. There you go. So now we can already kind of say, what does low thyroid look like? I can guess what high thyroid looks like. So let's do thyroid. Write it on the side. I put hyper on top, so I'm going to put my hyper and my hypo. But I'm going to name them. What is the most common type of hypothyroidism? Hypo. There's two kinds. One involves more children, developmental, and one involves adults. When a child is born to a mother who has low thyroid, and this can happen in general prenatal care. My daughter was pregnant and they said, your thyroid's real low, you need to take Synthroid. Because if not, the baby could have been born with mental retardation called cretinism. So hypothyroid, hypo, I put hypo on the bottom, I'm going to put cretinism in here. You need to associate this with low thyroid, which causes low IQ, but then there's also Hashimoto's. Have you heard of that one? So let's put Hashimoto's in there. Hashimoto. And we said, who does this affect? Women. Low thyroid. What's a common cause of low thyroid? Other than low thyroid gland production? Decreased iodine deficiencies. Have you seen that in some populations? So associate this with the iodine. Could be.
Do you mind moving the skeleton? Sorry.
Oh, sure. Please tell me. Yeah. Okay. So for whatever reason, the thyroid is not putting out enough hormone. So what does this person present with that could be a safety concern? We already said they have obesity, which puts you at risk for anything associated with that. So that whole thing's there, but all you have to write is obesity. And low energy. So someone with Hashimoto thyroid disease has a knee replacement, since that's our go-to. They're not going to go pepping and popping like, your 60-year-old business executive guy who golfs on the weekend and doesn't have that. So he's going to progress maybe faster. Again, how do you differentiate those two patients? How do you treat it? Artificial? Well, you can treat those things, but this part itself, medically, it is treated with artificial thyroid hormone. Synthroid is one. Okay, so Synthroid. Another one is called Levoxyl. Anybody familiar with that one? And this kind of taps into our pharmacology stuff, and we'll talk about how you're going to minimize all that too. It would make sense that you're going to take Synthroid if your thyroid is low. Like, you probably could not write that down and answer that on the test. Like, you got this, okay? How would they have tested for it, diagnosed it? T3, T4 levels. So let's just write those in the thyroid, T3, T4. Those are expensive panels. If you've ever had those panels drawn. Whew. Oh my goodness. If you don't have insurance that pays for it, that's about a $1,000 blood panel right there. Okay, so low thyroid. It's one that we hear everyday conversation. Oh, my thyroid is low. I can't lose weight. It makes sense. They have low energy. They need to take thyroid. So let's flip it over. What do you think hyperthyroidism might look like? And do you know the name of the most common one? Graves. Ta-da! Graves. And what do we know about Graves? Big eyeballs, right? It's the big eye disease. So if it's hyper now, how do you think that might look? And what's another, this is autoimmune. A little different cause. You might also see goiters. So what might be an opposite of this? What would be some conditions you might see? They might not be heavy, they might not be thin, but they may actually have tachycardia and CHF. So now we're getting back into the cardiac stuff because they're jacked up. The other people could use a little, jump start. Cardiac conditions. That's what their body feels like. Wonder why their eyes are big. So if you have to make up silly things and tease, Graves' disease, my heart is jacked up, low thyroid, I like the potluck. I'm teasing. If any of you have it, I'm not judging you for that. I'm just trying to help you remember on a test. It's like a silly song, okay? How would they be treated? They don't want any more of the thyroid hormone. They might be put on beta blockers. What is a beta blocker? It lowers heart rate, which is definitely a treatment for congestive heart failure, which is one possibility here, because it gives the heart more time to fill so that its contraction pushes out more blood. It's more efficient. We'll talk about all that in our vitals grid this afternoon. So hyper is beta blockers because they're all jacked up. Hypo is Synthroid because they need jump started. Guess what? There's the thyroid. Like,
Why would they have chronic heart failure? Is it because their heart's conditions?
yeah, congestive heart failure because of the tachycardia. They don't have enough time, so it backs up. Let's put tachy here. And we'll talk all about that and what those numbers are.
That's what was the other thing we were just looking up, because we talked about opposites. So with your hypo, you do have bradycardia.
Yeah, good one. That's why it's low energy. Good. Brady. So all you have to do when you're reading an endocrine question is find out which one was it. And you could almost kind of predict. Except for the next one is kind of a flip-flop of this. So we're going to do one more together, and then you're going to do some, okay? So are we good on these two? And these are some big, heavy hitters. So if they're going to ask you a question, they're going to ask you this. Let's hope it's one of these.
There's no lab or test or diagnosis.
You're just going to run, you're going to diagnose it with hormone levels, yeah. And if you see this goiter on the side, that's kind of a sign. And the bulging eyes, yeah. It's like
they have commercials. Pay attention to commercials.
Yeah.
Patients, because they talk about that all the time. The lady with the glasses.
Yeah.
Her sunglasses.
All right, we're going to do one more together. And we'll have time. Okay, we're going to do adrenocortical. Adrenocortical. And once we're done here, you guys can take a picture of this, but we also will give you the recordings. So hypo and hyper, does anybody know the conditions associated with adrenocortical? What pops to mind? Anything at all? Is that Addison's, did you say? So we've got Addison's, and the other is Cushing's. So which one do you think is hypo? Yep, and why did you remember that? Because they're cushy. But the crazy thing is, okay, so it's opposite of what you think for the thyroid. I'll give it away. With the thyroid, hypothyroid is the weight gain. With adrenocortical, it's the hyper that's the Cushing's, that's the weight gain. It's kind of opposite. So you have to realize for adrenocortical, the hyper is the fluffy Cushing person. It's just opposite. You just have to remember, oh, adrenocortical is opposite of the thyroid, which is a little less intuitive. I put my hypo on the bottom. So my hypo is Addison's, which can be a serious condition. Hyper is Cushing's, which seems backwards to me because I would think low would be the Cushing's, but this is opposite. SpongeBob Day. So Cushing's is the hyper. Too much. We could remember too much Cushing. Okay. So with the hyper, you have increased cortisol. And what do you know about those commercials? What's cortisol do? Makes you gain weight. It's the stress hormone. They always show that little diagram, that animation. This will reduce cortisol. You'll lose weight. So you have increased cortisol. And you mentioned the face. This is moon face. Hypotension. And weakness. That makes sense. Like these kind of make sense together, right?
Knowing they're backwards, you want to know how I remember those? In case it helps anybody. So Addison's is decreased cortisol.
Mm-hmm.
So people that have decreased cortisol have way too much stress and they've totally worn out their adrenal gland. And so therefore it's hypo.
And they are actually anorexic. Mm-hmm. Means they don't have appetite. Oh wait, I just did these backwards. Because I'm stealing someone else's chart that I had that does it backwards for me. So hold on. Hope you used pencil. I apologize. My brain is flipping on me. Addison's is the anorexic, the hypotension. Makes sense. Let me make sure, and you check me on this one. And weakness here. My bad. Make sure that concurs with what you have. And then the Cushing's is a moon face, obesity, and hypertension. Yeah, hypertension. Obesity. So Cushing's is obesity, hypertension, moon face, increased cortisol. Addison's, which is the hypoadrenocortical, is decreased cortisol. Okay, so the hypo is actually going to be the skinny little hypotensive person. The Cushing's is going to be the obesity and the hypertension.
In our book,
Is it flipped?
It says moon face weakness.
Okay, so let's make sure because I'm flipping you. Go with Cushing's. What's it say for Cushing's?
Cushing's symptoms are hypoglycemia, growth failure, obesity, purple abdominal stripe, moon-shaped face, buffalo hump, posteriorly at the base of the neck, weakness, acne, hypertension.
Hyper. Yep.
And then changes in mental depression for concentration, memory loss.
Okay. They both could have weakness for sure, but the hypertension, obesity, moon face go with Cushing's. We got that. Okay, and then your Addison's is anorexic, hypotension.
Actually, yeah, they both say weakness.
Yeah. So in that case, when they both say the same thing, you don't have to remember either one because it's the same. Okay? So let's just remember which one's hyper and hypotension. Obesity versus anorexic. Okay? How is either one of these treated? Do you have a basic treatment there? Meds?
Yes. Cushing's is pharmacology. I've never said that stupid word.
Pharmacological.
Thank you. Intervention to block the production of hormones, radiation therapy, and chemotherapy or surgery.
Yeah. So chemo, radiation, and also because of the hypertension, there might be some beta blockers in there. There might be some cardiac meds. Pretty intense stuff. And then the meds for Addison's.
Corticosteroids and mineral.
So synthetic steroids they're going to get. Synthetic cortisol.
DH3.
Is that what it's called? DH3?
No, I think that in addition to that.
Oh,
I think.
maybe.
Again, not my area of specialty.
Yeah. But do you see how with the endocrine system, you just need to know, is it hyper or hypo? And can you at least just put in the cheat words? This is just a cheat word chart. Okay? The cheat word chart. These are some pretty heavy hitters right here. If you knew this, the other only big category that will hit by itself is the pancreas with diabetes. That we could do on the chart, but we could also kind of build into that a little more. But okay, so we can look at the difference between hypo, glycemic and hyperglycemic, but we're going to do that on our safety chart instead because that's kind of a little different look. Okay, but does this make sense? This okay? So let's see what's our time running? 10:20. Oh wow. Okay, so well I need to give them their pharmacology cheat sheet packet. So what I've got for you. First of all, to finish this chart out, what I would suggest is jump to the systems you are very scared about. I would do gastrointestinal. Now, you're not going to have hypo on gastrointestinal. That was for endocrine. You're going to put your Crohn's disease. You're going to put your GERD. And would there be one other heavy hitter that you need to hit for gastrointestinal? Can you think of one, Lisa, that they should do maybe just to knock out the basics? Something that impacts absorption. Even if they just do GERD and Crohn's. So you're going to map out GERD and Crohn's on your own, and you are going to fit it in the box or you're writing too much. We already talked about with GERD, what are the therapy considerations? Positioning. With Crohn's, proximity to the bathroom. It's a pretty intense problem. And anything that affects gastrointestinal affects nutrition absorption. So they could have what? Demineralization of their bones. They could have malnutrition. Okay? So you have two sides of that pathology. You should be able to knock out the non-ortho, non-neuro systems on there with the heavy hitters. How do you know what the heavy hitters are? You look at your content outline that you've been given to see what you need to know about that system. So with gastrointestinal, read through that and go, okay, that's kind of sounding like I need to know about maybe this or that. And you fit it on there. And then when you study that, you just rewrite it. Like you rewrite it. See how much you can do from memory.
The other suggestion I would make about that is if you're rewriting it, the other thing you can do, especially if you do flashcards, write the questions. That's how I studied for my boards. I wrote questions like, what would be, we're going back to this, okay, what would, what pathology is a hypopituitary with increased growth hormone?
Mm-hmm.
And then I'd be like, okay, it's my other side of my flashcard would be agromegaly, which I'm not gonna be able to say well, but that kind of, that's how I always did it, because how are they gonna ask you those
Mm-hmm.
questions? How's it gonna be asked on exams? Is it gonna be, oh, look, Addison's? No, it's gonna be what, you see a patient who has hypotension and is anorexic, and they've said that they've been going through, they're on synthetic cortisol and DHA. What what might they have, and what do you need to be cautious of? That's what the question is going to be.
Yeah.
So write your answers by writing the questions, or study your answers by writing the questions.
Jeopardy.
Yeah, like Jeopardy, exactly, just like Jeopardy.
There's no shortcut to this. I hate to tell you. You are just going to have to study all day, every day. I mean, that's why we have this schedule and the calendar. Like, there's no shortcut. The last thing that you're going to worry about is coming out of the test going, I was over prepared. You will not regret that.
And
But
I
you,
can't
yeah.
emphasize enough, study together, right? You guys study together, didn't you? Okay. Study together. You definitely, because what one person, we're very visual people, correct? Okay. So somebody might be stronger in one area than in the other area. And so when you're sitting there and you have a question that you're like, oh, I'm not quite sure what, it might pop up into your brain. Oh my God, I remember when we were studying together and Jackie said, blah, blah, blah.
Right.
Okay. And as a visual person, you're going to be creating these pictures. Don't laugh at me, which could possibly help, So really, you want to try to study together, but look at them as true study questions, study activities, not let's have some drinks and eat some.
I was going to say, if your study partner's not serious, ditch them at the next off ramp, because that's not going to help you. But so real quickly, so I had a student that was very black and white, which was very frustrating for her going through PT school, since the answer to everything is it depends, right? And that is the real answer. And so for her to get through PTA school was very hard because she lived in boxes. She created this chart of pharmacology, which I refined and condensed a little bit for you. And so that is a student-created chart. That tells you the amount of work in the back side of things that sometimes is required to get through based on your learning style. But as you look through that, you can take that and add to your pathology grid just key things that you might want to put the meds or just to verify. But if you were to look at the groups of meds and you read through it, it almost makes sense. Like, what would be a side effect of a seizure med? It's trying to dampen the brain's reaction, right? So would you not be lethargic, right? So some of those things are like, duh. So you're going to rewrite that. Only the ones that don't make sense to you that you couldn't guess from a question. Like the ones that are like, oh, I would never remember that causes gastrointestinal problems. Okay? So it's just a summary. I'm not going to vouch for every word on there. It was a student-created one. But again, as you look at the categories, it kind of makes sense. So use your common sense when you're looking at these things. Don't be way out in left field that you can't make an educated guess of 4 options for your answer. Okay? So putting that together with your pathology grid, it takes the scary out of that whole section that you really need to spend a lot of time on. And it might mean reading through your pathology book, kind of cover to cover, to fill out the grid. And then after you're done, condense it to only the ones you need. But you will never, ever regret if that's 1 week of your study time of doing the pathology. You're going to have it down to 2 sheets. And you're like, okay, I got this. Okay? All right, let's take a break. When we come back, we're going to do iRobot, which will be a little more exciting, I hope.